Here, everybody. We're begun. So I'll take off where we left off here. Uh, Aside, and I don't think it'll happen in this. There's a call I might have to take, so it's rare that I have to do that. But if I have to do it, I'll do it. Let me see about my phone. Anybody out in virtual land, if you hear jingling, and ringing, it'll be me. This is where we left off. Strep throat. It's only part of it. See, there's a lot of different. Streptococcus has a lot of complications. These are two very significant ones, and it was a point that I added to you when I sent you some emails over the weekend. Two things. The one thing I forgot two things about those A/B toxins. Just look at the email. But surprisingly, they didn't. Most toxins, when we're talking about toxins, are typically gram positive, but they typically come, and even gram negatives, some of them have this. They have an attachment component and an active component and a binding component. B for binding, A for active, B for binding, and A for the active component of what makes it toxic. And they join when they're secreted, they're together. The B component attaches, and then the A, and it opens the door for the A component to do the damage. The other thing was this, what I recall that this is what we call a super antigen. And I'm surprised the other PowerPoint didn't make more of it from this textbook, from Cowan's textbook. It's a big deal. Again, there's a lot like necrotizing fasciitis and toxic shock syndrome we'll talk about. These super antigens super activate your immune system. They activate 20% of the helper T cells, produce a tremendous amount of interleukins and that's where the damage comes from. We call it a cytokine storm. Massive amounts of immunological products running around your system. And frankly, the amount of damage from those products, what they do on a tissue level, is remarkable. So a little works great, but a lot works badly. This is an example, scarlet fever. An erythrogenic toxin, a variety of things. Like you might recall me telling you, people who lost their hearing, people who lost their hair permanently because of complications. It can do almost anything. It's there. Rheumatic fever, which is different. Again, it's very well described as a cross reaction. Cross reaction, what I call lookalikes. Basically, the antibodies attack markings that are almost identical to streptococcus. It just happens to be on joint linings and the interior, the endocardial linings, particularly on heart valves, damaging them. So it's and a lot of the problems we see with people from years ago, I don't know how much today. Years ago, there were a lot of people who had who had rheumatic fever and ended up with that's the leading cause of heart murmurs. There's things that you'll learn about going forward called subacute and acute bacterial endocarditis. That is an infection, because infection can actually cultivate those damaged heart valves. Blood adheres to them, they become effectively a culture plate. And you have to be, just like you're growing in the lab, they're growing on the heart valves, and then effectively bacteria are being sent through the bloodstream and causing significant problems, many of which are life-threatening. So endocarditis, subacute means it's doing it without you really knowing. Acute, very, very severe life-threatening condition. So and you'll learn about those, and one of the things we would do is use antibiotics because of the risk of somebody have damaged heart valves. We give them antibiotics when they got their teeth cleaned, when they had surgery. There's various reasons why we use what's called prophylactic antibiotics. Damaged heart valves is one of them. Now, it has changed over the years because now we have a way of sort of reckoning the severity of the damage. Just because someone has a heart murmur, you don't have to do that. But if they've had a history of endocarditis, you likely have to. I'm not familiar with what the current guidelines are, certainly, but you'll learn about that. And so we're not done necessarily with that. It's there. You might recall that it's immunologic, so you get antigen-antibody complexes that can cause the kidney, and that's what happened to my stepson when he was up at Seneca Valley High School. He was 16 or 17 years old. They clogged his kidney. The kidney shut down. Now, fortunately, young, healthy individual. He did antibiotics, pushing fluids. Eventually, it cleared up relatively quickly. And that's what happens with young, healthy individuals. An older person or an infirm person might have had more significant problems. That, even though that usually comes from a skin infection, can come from a strep throat as well. So there's ample things that occur. So these immunological phenomena are many. And you're going to see when we start talking about necrotizing fasciitis, which is the flesh-eating disease, the most common culprit is this same bacteria, except rather than being from a throat infection, it's from a skin infection. About the second most common cause of skin infections after Staphylococcus aureus is Streptococcus pyogenes. And again, how easy does it get on your skin? You cough, you sneeze, you cover your mouth when you're coughing. Now you're going to touch your skin. It's going to get on your person. It's easy. So those are all part of it. So here, virulence of these phenomena, ability of antigens to mimic host proteins, that's the lookalike phenomena, possession of super antigens. And so that's a very interesting phenomenon. COVID was not really like that so much, but it created the same sort of an effect. The storm of what we call cytokines, we call pro-inflammatory agents. Agents that pro is short for promote inflammation. So different things. Now, it has its capsule or its outer layer. Lysozyme usually is very effective with gram positives, not so much here. Okay. Yeah, remember we have teichoic acid, something in gram positives. They help it adhere, particularly the cell walls of your throat, pharynx, resist phagocytosis. You don't have to know the specific. And here's the capsule, another one that allows it to adhere. And again, it makes it more difficult to phagocytize. So these are that's kind of what virulence factors are. Without going crazy with the specifics, I want you to be more familiar with the immunological implications as opposed to the specifics of this. I mean, you would not want to see that on a dark evening. All those little, I mean, that we see those tame little dots under the microscope, but protruding are all sorts of potential bad guys. Whatever they adhere to, whatever they attach to, what they produce. We're even talking about the toxins that it makes. So, I mean, there's a lot, and Staphylococcus is no different. And so it really is it's a telling image, I think, that we have to understand. It's all sorts of stuff, whether it's E. coli as a gram negative, whether it's staph or strep, all sorts of things stick out and have potential immunologic, toxic, adherence. All of those are virulence factors, yes.
So the toxins, can they make more than one toxin?
Yes.
And is it specific to the species, or are they just generalized toxins across?
The toxin themselves would be specific to species, but there are other bacteria do the same thing. So Streptococcus has what we call spreading factors. Okay, lots of bacteria have. They produce enzymes that weaken tissue and allow it to spread. Maybe they enhance clotting. Maybe they deter clotting. So it's the toxin that Streptococcus makes is unique to Streptococcus, but Staphylococcus makes similar ones.
And do they target something specific?
Probably not. Yeah, when you most of the time enzymes like that are general. So that's in lab. Remember we've talked about. I don't know if you guys did it with Dr. Dress with coagulase. So coagulase something when we get to skin. That's when we look at Staphylococcus. That's very specific to Staphylococcus. Very, very few bacteria, other than maybe something more exotic. But that's how we test to distinguish between different kinds of Staphylococcus. So Staph aureus is the one that makes that, and it coagulates plasma, and that obviously doesn't allow white blood cells and things to get to the party. So the nature of the destruction is different. There's so many different ones that are there. So it's a fair question to ask. So the best way I could answer is they're similar, but to some extent species specific. But I think they're more generalized than the damage they do. They're there. So one of the ways we identify it, alpha or beta hemolysis. Alpha hemolysis is more about strep pneumonia. which about a third to half of us have in our throat anyway. It's a big deal because strep pneumonia, other than being tremendously significant for ear infections, it's the leading cause of bacterial pneumonia in adults. And as you can see, that it inherently implies it has a greater potential for injury. The erythrogenic toxin and the severity of the rash varies. The redness is, as it were. But again, the superantigen induces fever, contains genes formed from a temperate bacteriophage can synthesize this toxin. What that means, you remember back, I touched it in passing when we started to look at viruses. Like, it means they've been infected by a virus called the bacteriophage virus, and it's allowed them to make this toxin. The same way botulism, the same way strains of E. coli, the same way various other kinds of gastrointestinal, they've encountered a virus that has given them, as becoming latent, basically incorporate that little bit of genetic material that says you can make this toxin. So down the road, I was reading an article about it, a short article, I didn't read it. They're starting to make news about these alternative ways using these bacteria. Most of these bacteriophage viruses destroy bacteria. That's going to be eventually your alternative to antibiotics. They can't hurt us, but they'll hurt the bacteria, thankfully. So 30% of sore throats, good ballpark figure, respiratory, direct contact, human to human, 80 different serotypes. So the fact that you got a strep throat 6 months ago doesn't preclude you getting it. When they talk about serotypes, that's typing them in your serum, in that portion of your blood, which is basically your plasma minus the clotting factors is called serum. So we used to refer to serotypes, meaning these are all different. It's the same thing with the common cold. If you want to think of it from a virus, there's 100 or 200 different kinds of common cold viruses. So you're not going to, it's very unlikely that they're going to have immunity. Here, 80 different types. Okay, this is where they talked about that group A, that carbohydrate. I mean, I would be surprised if you can find anything online just about. Okay, so, and that, like I said, it behaves very much like I said, like a pregnancy test or a COVID test. One line forms another line. And then obviously all the different things. We put a lot of stuff on blood agar. We look for beta hemolysis. That's there. It differentiates from group B. Enterococci don't have any hemolysis. Group A, I beg your pardon, alpha hemolytic, different. So, beta hemolytic, group B is a slightly different strain, enterococci, and we use that bacillus disc. That's just worth remembering. No vaccine, usual things, hand washing, covering your mouth, coughing and sneezing, etc., etc. Nothing here. Penicillin still work. This is absolutely incorrect. That is absolutely, and you'll see that on that. The drug of choice for penicillin allergic is not a cephalosporin. What were you thinking, PowerPoint writer? It is. Please don't come to me. I saw it on the PowerPoint. I'll go crazy. Erythromycin is the drug of choice for people who are penicillin allergic, period. Can some people be treated with cephalosporins or cephalexin, which is Keflex? Sure, but there's still a 10% cross-reactivity. And yeah, most of the time they can resolve on their own, but I think the part that escapes people, why we treat it, well, my throat isn't that bad. The strep throat, you need to treat it because of these problems afterwards that they commonly call sequelae, which are really complications. But again, sequelae is the nice term because complications, when you hear the word complications, patients start getting ready to look at one of those numbers you see advertised on TV. Hello, Edgar. I told you my daughter and his daughter went to the same preschool up at the Jewish Y up in Squirrel Hill. Just say it. No, they were in kindergarten together in a Jewish day school. More and more by this, I am unfamiliar with this fusobacterium. Adolescents and young manifest a severe sore throat. I am unfamiliar with this. I'm not going to ask you about it. I'll try to make myself more familiar with it. Okay, with this, and as we have better techniques of identifying things, this was the kind of stuff. So it's I'll do some looking around and see about it. So much for strep throat. The other strep throat is not nearly as common as this bad boy. 200 different types. Again, they use the term serotypes. Okay, so rhinovirus is predominant. Coronavirus, or COVID came amongst us. Coronaviruses still are, most of them are very, very tame common cold viruses. The bad cold, the one with the swollen glands and the sore throat, adenovirus. Most of these don't cause fever. Adenovirus have a mild. That's sort of the distinction. RSV is getting more ink because now RSV being an RNA virus probably has altered over time. I remember it's in the same categories as mumps. Okay, it's called a paramyxovirus. It's an offshoot of influenza. It's similar to influenza, which means it changes. And now we're starting to see fever problems with RSV. My mother-in-law, before she died, one of the things that put her one time in the hospital, she tested positive for RSV. A lot of times when people test negative for COVID, and they have COVID, quote unquote, like symptoms, cough, pain, most likely it's an RSV. So now they talk about the big three, and of course they want everybody to be vaccinated. Influenza, COVID, RSV. So respiratory syncytia, if you remember, since what it does, and that's the leading cause of respiratory distress in the newborn. It causes fusion of cells. We are able to resist it, so it just for us, it's less likely to be, unless it's for the very, very young, like the newborn or the very, very old, like my mother was. That was 3 or 4 days in the hospital, a lengthy rehab stage before that home. Again, indirect or direct contact with droplets. Again, all these things, cough and sneeze, they're in the air. You can contact them. Okay, directly if someone's next to you. Indirectly, if it gets on a surface, it touches the surface, any type of contact with sneezing, scratching, we know it. Fever in adults less likely. Their children may more likely. Again, the adenovirus is that bad cold. They've talked about vaccines for adenoviruses. Again, there's a lot of types of that because they're more severe. Again, the idea, people today forget vaccines have risks. There's a lot of complications, statistically speaking. There's an ascending paralysis I mentioned to you before called Guillain-Barré syndrome. That's part of it. People can have COVID vaccine, or in many cases of myocarditis, inflammation of the heart. It's not innocent. It's a risks and gains. Why? The cold's not going to kill you. It'll annoy you to death, but it's not going to kill you. That's what I tell my patients. Okay. There's nothing about that. So with conditions like that, why take a risk when something is, the same home remedy works every time, 7 to 10 days, fluids, get plenty of rest. Sound familiar? We call that MOM 101, Mom 101. Go, Ruthie. Finally shared with my sister that I'm going to be a great grandpa. You're going to wake her up. I'm way ahead of her, though. She's older than I am. Causative agents. This is sinusitis. Again, sinusitis, otitis media, and even though this textbook doesn't necessarily have it, conjunctivitis. Viruses, bacteria, about 1/3 of the time it's viruses, about 2/3 bacteria. You don't see fungi. When I see fungi infections respiratorily, I think immunosuppressed, allergies, people with certain kind. When you talk about structural, it could be anything from a deviated septum to problems with sinuses that have been clogged previously. Again, I think this is broad spectrum antibiotics are something to start with. You learn nothing from the antibiotics. chapter, we start broad and we narrow it down, we cone it down. Broad spectrum kills gut bacteria, leads to colitis, leads to diarrhea, leads to a lot of gastrointestinal problems. It's ludicrous. This was the old way of treating it. Well, I'll hammer it, it'll be dead. The only trouble is you keep familiarizing bacteria, these antibiotics resistance is going to follow. Yeah, when you're talking about fungal infections, you got to clear them out. And usually they're stuck in there vis-a-vis a blockage, would be the way to describe it. So, and again, the big two that we see consistently for sinusitis, for otitis media, for conjunctivitis, when it's bacterial, are these two. Streptococcus, even though we harbor both of these, approximately half of us harbor both of these, one or more of these, certain Streptococcus pneumonia, we call H flu, which is short for Haemophilus influenza, and they're not difficult at all. I mean, again, the whole idea of amoxicillin, which we basically became the treatment of choice based on the research here at Eye and Ear Hospital in Pittsburgh, have been around forever. Augmentin, okay, if it's a beta lactamase producer, it's not difficult to treat comparatively speaking. It's just that I think it's a matter of recognition and making the determination. If it's viral, you would generally have a shorter course. If it's bacterial, now you look at the changing colors. When you start to get that, you go from clear mucus to that mucus that's kind of like, oh my goodness, weird looking colors that are on there. It's like, ugh. So, speaking of otitis media, upper respiratory tract, because of the anatomy, principally inflamed eustachian tubes, fluid in the middle ear, bacterial multiplication of fluid. So they didn't put the Haemophilus influenza. Yes, that's a yeast. Classify Streptococcus pneumonia, I'll grant you, is probably number one, but Haemophilus influenza, I think, is number two. Okay. I mean, I don't know. Again, it's whatever the doctors are. When it comes to vaccines, are there vaccines? Sure. I understand these things. To me, I don't know how much of this is commercially oriented. In other words, how much of it relates to money and how much of it relates to therapeutics. You have to be comfortable with your family doctor or your pediatrician is. When you're working, if you're from the facility you're working at, you can have your own, I'm going to tell you this frankly, you can have your own opinions on what's right and what's wrong. If you're working in a facility, it's their opinion. It's a nice way of saying don't buck City Hall if you want to keep that job. I'm fond of saying, look, I'm very glib here. I'm at the stage of life where they don't like what I said. What are they going to do? I got one more year, maybe two out of me. If I'm not here, I'm past that stage of being frightened about things like that. You're not. And remember, for everybody, when you're working in any facility, including this one, never say anything that you don't want to have repeated. Okay? You may think you're surrounded by people who are your friends and everything else. Don't bet money on it. I hate to be an old curmudgeon. It's true. Listening to me? Listen to me. Don't. You have to understand there's a place and time to express your opinions. And you can't, whatever company policy is their policy. You're a newbie. Okay? If you're on an infectious disease control committee in a committee meeting, that's different. Now you've reached a certain stature where you can have that discussion. Okay. I'll buy watchful waiting. Antibiotics. And again, I don't know what the current theory is. Typically, it would be 7 to 9 ear infections in a matter of a year span. You start thinking about that. Why? Putting tubes in the ear? Because You're concerned that there may be some type of long-term damage. And it's in children 2 to 4. How do they learn? How do you learn how to speak properly? Okay? Hearing is such an essential part of it. Vision and hearing, because you're mimicking sounds. You know, whether it's the cat's name or the dog's name or this or that, you know how little, you know, you've all had fun with that over the years. So hearing is very important. My daughter, a lot of ear infections. Again, who knows? I mean, with adoptive children, you don't get a lot of information to understand there's something underlying with regard to that or not. So she had a set of tubes when she was 2 and another set of tubes when she was 4, and eventually did have to have her tonsils out. So all of those were part of it. So, you know, and so the tubes have been, and it's very easy to do. It's a 5-minute procedure. They put the little kid to sleep, tiny stab incision, boom, boom. The tube kind of looks like a mushroom cap. So here's the tympanic membrane, here's the outside of the ear. And basically they insert, it's called a cannulated tube. So it looks a little bit like that. Basically it's got, cannulated means it's got a hollow center, a cavity, like a tube throughout it. Very, very tiny. And it's a ventilation tube, basically allows drainage to come out. That's how they work. And over time, as it begins to heal, so it's got this cap part so it doesn't go in the middle ear. As it begins to heal effectively, as this begins to heal over, it pushes the tube out. And so what happens when that tube is expressed or pushed out, a lot of times parents don't even notice it. Doctors will tell you how long it is. They'll push it, it'll push out. You'll find it. Sometimes it'll happen when you're bathing the child, or the child's bathing. A lot of times there'll be drainage, like on a pillow. And you know, sometimes you'll feel like a little, lack of a better way to express it, sort of a rubbery speck. Yes.
Is that why that they need to be replaced so often?
Yeah, because sometimes they get pushed out sooner than not. And really, it's if they're prone to it, like my daughter. I mean, we thought when the first set came out, okay, we're okay, and then, you know, still getting more infections. Probably that anatomical basis, the nature of some kids being more prone to it than others. So they're showing you here. And so, like I said, it's going to be inserted this way because what it does, it's a drum head. If it bulges, it can't vibrate. And what happens when it hurts? It hurts. That becomes inflamed very readily. They usually, and the other, I don't have the PowerPoint here. They usually, and I'll conjure up that other point and show you the pictures. So when it comes out on the bed and you have that little rubbery, what do you do? You're a mom or a dad. What do you tell your parents or to do with that little rubbery tube? Any ideas? Tube fairy. Under the pillow. You have a tooth fairy. Why wouldn't you have a tube fairy? I will give the kid a few bucks. I would do that. I know it's a pejorative term these days. The tube individual, the tube mythical creature, just like the tooth mythical creature. This is me getting myself in trouble. Sorry, not going there. So I have no idea how do I know if it worked? Don't care. Here we go. That kind of short shift for upper respiratory infections, the one that I think that they should take the time about is the adenovirus. It's a cold, but that's characterized by even in adults, a low-grade fever, 101, 102. You're not unable to function. That throat that feels like it's on fire. The glands are distinctly swollen, and to me, it's the old bad cold. And I think RSV would characterize it that. RSV more of a significant cough. I think we have to look at those more closely today than we did years ago, even though we have to acknowledge RSV's role in children, and particularly the acute respiratory disease of the newborn, and particularly in preemies. So I think that's part of it too. I'm going to look too, because I have stuff. If you saw that thingy, I know I hate to use scientific terms. It's on that outline, those respiratory disease notes. You can see it's more neatly typed. One of my students did it for me. So here's the strep throat, spreading factors, interfering with body defenses, superagents, and toxins. The complications are there, significant problems. Here's the endocarditis, antibiotic prophylaxis. See, they didn't talk about diphtheria, and they should. So I'm glad here, epidemiology. I'll do the diphtheria nugget if I don't see it. Pink eye, again, H flu, Haemophilus influenzae, and streptococcus pneumonia is on there. So I have it in my notes. Here's the rhinovirus, adenoviral pharyngitis. Okay, here's the one. Okay, I got to tell you the story. Here's diphtheria. You won't see it. You're immunized for it. One immunization certainly is important. That's DPT. And when you get a tetanus shot, I've said it before, you get 3. Diphtheria, pertussis, whooping cough, and tetanus. Trivalent. Very rare, still deadly when there's total vaccine laxity. And I mean, this one doesn't make a lot of sense to me. It's a gram-positive, non-endospore-forming rod named Corynebacterium diphtheria. We have a whole category of gram-positive rods that are normal in our throat, normal in our skin. We name for it. We call them diphtheroids. The OID suffix means it looks like diphtheria, but it's not. So the OID means it looks like diphtheria, so we call them diphtheroids. Starts as a sore throat, but progresses frequently to fatality. People who are not immunized, even if they get antibiotics, we're looking at a death rate in terms of like 10%. I'm going to tell you the anecdote in a second. Problems relate to the release of a powerful exotoxin, which is released, again, one of these lysogenic conversions has been infected by a virus to make this toxin. Okay, it forms a membrane on your throat. That's the start of it. It peels off that membrane and thickens, so they can't breathe. It's, ooh, I can hardly breathe. That's not all of it. So it has clotted blood, epithelial cell, white blood cells. It can loosen and obstruct the airways, suffocation. The toxin produces extraordinary pain, can clobber your kidneys, damage your heart. Here's the anecdote. The first year I taught micro to nursing students. Having talked about micro with other classes was almost 25 years ago at Chatham. My first class at Chatham. I was doing micro for 80 plus students in this big auditorium type, one of the big lecture halls. The interesting anecdote, this woman, because a lot of non-traditional students, not like your class here. We had like, most of this student, I would dare say she was mid-30s. Very, very good student. We'll start with that. There's a reason. She was a doctor. She was a psychiatrist. She was from Russia. She had her medical degree from Russia would not come to this. She had, and it cost money to be able to take the courses and do the testing to cross over. So she had married a U.S. guy, obviously, and they had a child. She came here and she said, look, it's an 18-month program for nursing school. So I'm sure she was going to zoom right through it. And I'll start making money as a nurse, work a couple of years. And enough time when the baby's older, I'll reach my degree. She had been for her residency. They had sent the part of her residency out in Siberia when they had an actual diphtheria outbreak. She proceeded, no joke, she proceeded to sit there and she would tell the whole class, mouths, mine included, were dropping. She told them about what actually diphtheria was like. I said, you can't believe it. Everybody, these people were trying to breathe, rolling around on the floor, screaming in pain and dying in front of our house. Thousands of people, it's documented, died in this outbreak circa the late 90s, 2000. We don't see this. That's why this was, people realized that was one of the early vaccines. Whooping cough, diphtheria, tetanus were everywhere. The toxins were very simple proteins that they could extract, heat, create toxoids safely, and inject them into people, and you'd have an effect. It's not that no one cares about the sore throat, it's not going to kill you. It's all about the toxin. Very, very so. It's fascinating. So, absent disease has shifted adolescents and adults to the lack of exposure, boosters in certain populations. But the key is 1 out of 10 die from severe toxin, even with antibiotic treatment. It's the toxin, so prevention is the key. Same is true for that. And interestingly, whether they have whooping cough on this particular, on our PowerPoint sequence from Cowan, I do not know, because I don't recall. Understand that where we see whooping cough today is mostly in older children and in adults when they have a chronic cough that lasts for months and months. A lot of people are diagnosed with whooping cough, not whooping cough per se, but are test positive for the quote-unquote pertussis bacteria and have to be treated with long-term antibiotics. It's like, you go to, I've had this cough since I had this terrible cold, and in 6 months I can't get rid of it, and they start doing additional testing, and son of a gun. Then it turns out they find it there. So that's a lower, pertussis is because it's classified as a lower respiratory infection. It may or not be here, but while we're here, let's talk about pneumonia. So I'll buy it. It's a highlight disease. The lungs fill with fluid, typically fluid that has a pus component, varies as to how much pus, how thick the fluid is, all of those types of things, but they fill the alveoli, and it's sort of like you're drowning inside, because with all that fluid, you can't exchange oxygen and carbon dioxide. And there's a whole bunch of things that cause it. Bacteria, viruses, and fungi, okay, must have some type of characteristic that allows them to survive there, and by and large, it goes to one word: capsule. They have a big, thick capsules, resist phagocytosis, or if you like bacteria, if you're like tuberculosis bacteria, rather, it will be swallowed by a macrophage and set up shop and start to replicate it. So they have adaptations to resist either phagocytosis or not, or are unable to be destroyed, even if they are phagocytized that are there. So they avoid phagocytosis or avoid being killed, as I said. Deadly across the globe. More children under the age 5 die of pneumonia than any other infectious disease worldwide. Again, in our country, the leading infectious disease that kills still is pneumonia. So we'll talk about a few of these that are significant. Number one on the hit parade, streptococcal pneumonia. The pneumococcus, this is a famous experiment. The doctor was looking to see, it was kind of the way starting to look for a phenomenon called transformation back in the 20s. And this was the way that lateral transfer of genetic material, how bacteria could, in the same population, could change each other. And he actually, it was all about the capsule. He did a famous experiment. He had streptococcus pneumonia that under the microscope had a capsule, streptococcus pneumonia that didn't. What he did was when he injected the one with the capsule, that was the one that caused bacterial pneumonia into mice. The mice died from pneumonia, just like you and I might die. When he injected the one that didn't have the capsule, they didn't die. And his name was Griffith, by the way, still in the 20s. He reasoned, therefore, that the capsule was part of the deal. So he said, I know what I'll do. He heated the bacteria with the capsule, and he injected them. And what happened was the mice didn't die when they injected them. Then he said, this is interesting. He said, I wonder if I take some of the dead bacteria that have the capsule and mix them with the ones that don't have the capsule. He did that. He injected those into the mice, and the mice started dying. Cultured out from their lungs, he found many of the bacteria had started to grow a capsule. So what came from that is he said there's something in the dead bacteria that can still change living bacteria and change it from being innocent to virulent. That was the first time we knew about material moving. He just didn't know whether it was proteins or DNA. It turned out it was DNA. We couldn't prove that until the 60s, when they could take radionuclide imaging. In other words, they could tag phosphate and sulfur with substances that they would be able to identify what we call radionuclides. Okay, so they were emitting radiation that could be tagged and identified. Fascinating. So pneumonia's been a big player for forever. This just gives you an idea, and this was sort of the poster child for it. Things traditionally, the very old, the very young, underlying viral respiratory disease. Typically, what happens? They had the flu or some other viral lower respiratory disease, respiratory infection has damaged the cilia, has damaged the mechanism, has damaged the mucus in some way, shape, or form. Something has happened. Diabetes, and certainly any type of lifestyle factors that are disfavorable. Really very nasty. Thankfully, again, for years, penicillins worked just fine. Now they're starting to find, this is one of the things that you look at in our chapter when we looked at antibiotic resistance, we're starting to see problems with penicillin and penicillin-like substances. It's something that used to be routinely easy to treat, Streptococcus pneumoniae. So that's the number one player. And you should remember, I'm sure that's on the test. That is there. So let me see if I have enough. I have another anecdote. Legionnaire's disease. You're excited. See, it happened because of military people. Aren't you excited? That's a great name. They named Legionella pneumophila. So, as that was to happen at, I'll give it there. Bicentennial. I don't think any of you were alive in 1976. It's almost 50 years ago. Okay, probably not. Okay, just joking. 1976, they had the bicentennial in Philadelphia, where I was. They had bicentennial all over. Philadelphia, big time. Liberty Bell, the whole 9 yards. They had a giant American Legion convention at the old Bellevue Stratford Hotel in Rittenhouse Square. If you're familiar with Philadelphia, it's a very old area. The hotel was kind of like our William Penn, the same genre. Okay. What happens in older buildings built Civil War to maybe 1900, they are grandfathered in when it comes to building codes. For us, when we built this annex, all the ventilation, the piping, and everything else had to be up to a certain code to prevent certain problems. These buildings didn't, but they say grandfather, we're not going to have to redo it. In the old days, you'd have a crawl space, and in there you'd have the hot water, the cold water, electric, heat, all different pipes and things like that. And what it had university was dust. It had this particular set of rooms leading into it had a leaky water pipe. And what happened is that leaky old water pipe and the dust contained a particular bacteria. We did not know that. That's what actually happened. This is a bacteria that we call very fastidious. It only grows in warmer than room temperature climates, think hot water, or warm water associated with dusty environments. There's a particular environment, and these crawl spaces, they're like culture play. Here's what happened. They didn't know this because when you go, if you go to a convention and you're with a big group, you have the lectures in the same rooms. They partition them off. You have dinner in the same rooms, and these were some were World War One vets still alive. World War Two, Korea, Vietnam, all those eras were there, and they're in a relatively close space. And in the evenings, after they have lectures and presentations, they'd have movies. They'd sit around and swap stories. They'd all smoke. They were all drinking, and they're all breathing the same air continuously for a week. What happened afterwards? They started to get very sick. 15 or 17 died. They thought that this was a recurrence of the very famous Spanish flu because they had World War I people in there. Something triggered this. They got the leading authority on viruses, the lead virologist in the Commonwealth of Pennsylvania, who happened to be my virology instructor, Dr. Satz, Jay Satz, to investigate and find the virus. He could not. The reason is it wasn't a virus. It was found out it was a bacteria. They named it Legionnaires. They call it Legionnaire's disease. It's a flu that's characterized by severe gastrointestinal symptoms. Anybody who was infirmed or old or had a lot of risk factors like drinking and smoking, read it as the Legionnaires, was likely to succumb. And so they found that out. It is still difficult to treat. And the tragedy of all this is the most recent outbreak of significance. There have been a couple. Unfortunately, have it right here. Vets Hospital. I won't even get into the beginning. Vets Hospital in Pittsburgh, they had, again, problems with their water system and a confluence of factors. And there was a major outbreak of this. And it's very, very hard to treat in somebody who's highly depressed. So it's a gram-negative bacteria that I don't know. I think it's more about the identification, and typically the people will have, because there's a higher than usual fatality rate. I'll leave it there. We'll pick up with mycoplasma and chlamydia and histoplasma, et cetera, et cetera, et cetera. Thank you.